Hi, my name is Beth Ekman. On behalf of the Honors Program, St. Edward's University, I'd like to welcome you to the Fall 2019 Honors Symposium. Our next presenter is Lauren Fogt, and her advisor is Christy Ballard.
Yes, she's right there. Hi, my name is Lauren Fogt. I'm a pre-PT major on the Hilltop, and thank you for coming to my thesis presentation titled Physical Therapists for Psychologists, a comparison of group and individual physical therapy and their effects on post-injury depression. First, I'd like everyone to take a look at these lists of words. Wordlessness, anger, irritability. If any of these words jog up certain memories from your life, please raise your hand. As we can see by the looks of the room, it affects a lot of people. These feelings are hard to experience, and that makes them hard to talk about. This is the focus of my thesis. The collection of these symptoms is known as depression, and it should be noted that not everyone experiences all of these symptoms when they do have depression. So what is post-injury depression? Post-injury depression is a mental comorbidity that occurs along with a physical injury or a physical dysfunction. It should be noted that for it to be diagnosed, these signs and symptoms of post-injury depression need to persist for 2 weeks or more. The risk factors of post-injury depression include being female, having low income, having a previous mental disorder, as well as having one of the major 5 personality traits, which is neuroticism. This is a long-term emotional state of anxiety or negative feelings just in general. I'd also like to touch on the method of treatment. The method of treatment is important because it impacts patients directly. It's important because that's at its initial onset. With post-injury depression patients, as it develops, it's harder and harder to combat. In my thesis, I talk about the roles of physical therapists. They have a role in identifying post-injury depression, and they can achieve this by being aware of the signs and symptoms as well as the coping mechanisms involved. In my thesis, I highlight on 2 coping mechanisms, maladaptive coping and avoidance coping. When one is confronted with a new situation and they adopt an incorrect strategy of dealing with that situation, that's maladaptive coping. This would be like having 2 tasks due tomorrow. Let's say one of them is running your 20-page thesis, and the test also that you have to study for. But instead of working on these 2 tasks, you do something else like cleaning your house or talking to a friend on the phone. Avoidance coping is just procrastinating in general. When one is presented with the new situation, they deal with the stressor by avoiding the stressor. These 2 coping mechanisms serve as predictors for post-psychological experiences. It's been shown that the more severe the injury is, the more severely they'll be presented to the physical therapist. Also with these coping mechanisms, the later they're noticed in the rehabilitation recovery, the harder they are to combat, and there is a threat of them creating a stagnant period in rehabilitation. In one study, it was shown that 15% of patients experience PID, post-injury depression. This was just in a study of 700 participants. In another study, it was shown that up to half of all trauma patients are affected by post-injury depression. This is a wild number, and it's important because PID is a dominant contributor to patients' inability to return to original function 1 year post-op, and this is because of its paralyzing effects on both the physical and mental recovery. Yet, knowing this, it's surprising to hear that PID is rarely explored in the context of physical therapy. I chose to hone in on PID because during my volunteering experiences needed in order to apply to PT school, I witnessed a lot of conversations surrounding fear. Fear of patients to engage in certain exercises, and PTs were skillful in identifying these as coping mechanisms leading to a diagnosis of PID. I chose to also hone in on individual and group physical therapy because during these volunteering experiences, especially during my first one in a clinic, a sports medicine clinic in Houston, I witnessed group physical therapy and the power it has to motivate patients to motivate each other. courses of treatment for PID patients. There's psychotherapy or talk therapy. There's the pharmacological approach, which includes beta blockers and SSRIs. And it's been shown that SSRIs are less effective with combating PID. There's also exercise, and with exercise, more neurotransmitters such as dopamine and serotonin are introduced to the brain, overall alleviating the symptoms of PID. Physical therapy happens to include exercises, so those PID patients are already at an advantage of overcoming their symptoms. The two formats of physical therapy I touched on, or I highlighted in my thesis, are individual and group physical therapy, which I will be now calling IPT and GPT. And IPT, it's a direct relationship with the PT and their patient. With this, their individual needs are met, as well as a more confidential environment for the patient. Some of the disadvantages of IPT include, for the clinic, more staff being needed during that time, as well as a loss of benefits that come with group physical therapy. With GPT, it's usually a setting in settings such as skilled nursing facilities and inpatient facilities. With these appointments, patients will be working together, usually 2 to 6 patients. They don't necessarily have to have the same injury. The PT doesn't have to have direct contact with each patient, and they'll likely have a physical therapist assistant, a PTA, there also. With GPT, PTs need to constantly be monitoring patients in the case of a fall, especially with the geriatric population. Some advantages of GPT include more motivation among patients because of that group support, and a less staffing for the clinic itself. For the disadvantages of group physical therapy, it's more demanding on the PT, and there is that component of less confidentiality. Once my study was approved by the RRB, I sent out a preliminary questionnaire to physical therapists, those who could possibly have relevant experience relating to my topic. Over the course of 3 weeks, 26 participants completed the survey, but only 5 had relevant experience. Once these 5 consented to an interview, I conducted about 20-minute interviews with each one, following a semi-structured protocol. With this, I had questions prepared beforehand, but if I felt the need to clarify, I would ask a follow-up question. Lastly, I conducted qualitative analysis using the grounded theory approach. With this approach, I went into the study without having any hypotheses or preconceptions whatsoever. I let the data speak for itself. With the grounded theory approach, also, I wrote down the emerging themes, interconnected the themes, building story, and finally created a composition off of these. So overall, there were 5 participants in my study. I chose to include 4 PTs who had an average of 12 years of work experience. And I'd like to note that I also included the PTA, the physical therapist assistant, because of the amount of work experience she had and the valuable feedback she had about GPT and PID patients. So overall, interviews proved to be extremely valuable, and I'll pass out my interview protocol so you can see the types of questions I asked. This PT in particular pointed out the importance of GPT for PID patients. She told me that she would pair up patients and present them with exercises to do. She would empower them by saying, okay, you have the time, space, and equipment to now do your exercises. And she'd often say quotes like, okay, this is your gym. With this sort of mindset, she witnessed more accountability among patients, and they were overall more motivated to be experiencing physical therapy together. She also mentioned that patients after their appointments would stay and check up on their peers to see how they were doing, which was really powerful to me. The first emerging theme I identified in my thesis is PTs would identify themselves using terms according to multiple roles. within each format. So the first role that they would identify themselves under was liaison. They would communicate between the patient and their medical team in order to make sure that individual needs were met. Secondly, they would refer to themselves as an educator. They would explain to the patient the extent of their injury and what their rehabilitation protocol would look like. Patient education is extremely important for PID patients because it does help with the mental recovery side of things. Lastly, they would refer to themselves as guides. They were not their patients' peers. And with group physical therapy, it's evident that that peer interaction is a benefit overall. With IPT, patients were more likely to break barriers, especially in patients in inpatient facilities going to their homes within a time frame of 2 weeks. They would need to work on going in and out of doors in wheelchairs, getting on and off the toilet, and these aren't things that can be addressed in a group setting. There's also post-op importance. IPT is the suggestion among surgeons for patients who are leaving surgery. GPT is often contraindicated because of the advanced phases that are associated with it. With GPT, PTs would refer to themselves as facilitators and leaders. They would view GPT almost as fitness classes, but with the need to monitor their patients even more to assess whether or not they're about to fall and to redirect conversations, especially if they became negative. With GPT, I already mentioned that it created motivation among patients, and there is the caveat of needing to have advanced patients engaging in more advanced exercises. So now we know that with IPT, it addresses more of the physical benefits, but with PID patients, the focus is the psychological recovery. Psychologically speaking, there was a tie. PTs found it hard to quantify the benefits associated with each format of physical therapy. With GPT, they said that it was a non-medical modality. The more of these in a patient's recovery, the better. Although there was that component of the negative conversations that could potentially occur. With IPT, they found that it was more effective, but in the end, the physical therapist is not the patient's peer. A patient is more likely to relate to someone who is going through the same things that they are, and in the end, a PT is not. There's also a need for a multifactorial approach. With each interview, I, along with the PT, noticed that there were several things coming up, several factors. One PT in particular said that she worked in Houston and also in a rural community in Tennessee, and she witnessed a drastic change between the two. Patients in Houston would have 3 scheduled appointments a week, but they would show up with the mentality of, here, face me. But in the rural community, they would have 2 scheduled appointments per week, and they would emphasize more of a personal connection as well as doing more of their exercises at home. With this PT in particular in the rural community, she said that if patients were more faith-driven, she would even pray with the patients to promote their mental recovery. So because of this tie for the psychological component, as well as the multifactorial approach, I created the combined approach. With this approach, a patient directly after surgery undergoes phases of individual physical therapy, and once their PT identifies whether or not they're at the functional level to start engaging in more advanced exercises, then they would start interweaving IPT and GPT in order to promote both the physical and psychological benefits. With the intention of the combined approach is that where IPT falters, GPT may come in and compensate for the lack of benefits associated with that format of physical therapy and vice versa. I should note that literature does address the combined approach, but it does not specifically hone in on PID patients. So with that said, there are some limitations with this study. There was a time restraint. It was conducted over the course of 3 months. And with this, there was a lack of patient observation as well as patient input, 2 things that future studies should really keep in mind. Future studies should also hone in on isolating the factors that were in that multifactorial approach as well as evaluating the effectiveness of the combined approach that I created. So the overall goal with this is to have PTs help with a 0% occurrence rate. Their role in assessing PID in patients is to be aware of the signs and symptoms, the coping mechanisms. But as soon as they realize that the patient's symptoms are threatening their recovery, they need to know when to make that necessary referral back to an individual on the medical team. It could possibly be the clinical psychologist or a physician that is close to the patient. I hope to use the combined approach one day as a PT myself, and until then, I will spread knowledge of my research to other practitioners in the field. Thank you for watching my presentation. I'd like to thank Dr. Ballard for being an amazing advisor and for encouraging me throughout this process, and for the honors program for granting us this opportunity to explore our field before we were even in it. So thank you so much.
As Dr. Ballard makes her way to the front to grant Lauren her stole, I think we might be able to take one or two questions. Any questions? Would you like to say any words about Lauren?
No, I would say I've known her for 3 years now. I've had her in classes. I'm her academic advisor. I helped her through this process. She's been a joy to work with, and I wish her well in everything. She's going to do great.